Today we will be discussing pediatric asthma management. My name is Abigail Carpenter and I'm a student at Ohio Northern University, and I will be presenting with Megan Gill, a pharmacist in general pediatrics at Cincinnati Children's. The learning objectives for this presentation are to discuss the clinical presentation and pathophysiology of pediatric asthma, to review pharmacologic agents that are used in the treatment of pediatric asthma, to identify the recommended changes to pediatric asthma management provided by the recent guideline updates, and to recognize the treatment options for management of an acute asthma exacerbation in pediatric patients. I would like to mention today with this presentation there are no conflicts of interest to disclose, and off-label use of medications will be discussed. Asthma is defined as a heterogeneous disease, usually characterized by chronic airway inflammation. It's defined by the history of respiratory symptoms such as wheezing, shortness of breath, chest tightness, and cough that can vary over time and in intensity, together with variable expiratory airflow limitations. The prevalence of asthma is 8.1% of children with a diagnosis of asthma. Asthma is more common in boys than in girls, and children ages 12 to 17 are most affected. African American children have the highest rate of asthma, and the highest prevalence of asthma are those living at 100% of the federal poverty level. Next, we will be discussing the pathophysiology of asthma. The pathophysiology of asthma involves the infiltration of inflammatory cells, which causes damage to the epithelial cells. This leads to the classic features of asthma, such as airway swelling, increased mucus production, and bronchial muscle dysfunction, which produces airway flow limitations and asthma symptoms. Ultimately, remodeling occurs, which can lead to fibrosis, mucus hypersecretion, epithelial cell injury, smooth muscle hypertrophy, and angiogenesis. This picture depicts a normal airway versus an airway of a patient with asthma symptoms. So as you can see, with patients with asthma symptoms are going to have a narrowed airway with the limited airflow, have tightened muscles which constrict the airway, making it difficult for the patient to get breaths, and then inflamed, thickened airway wall with secretions, making it hard for the patient to breathe. Next, we're going to be talking about the clinical presentation of asthma, such as signs and symptoms, diagnosis, and classification. The classic signs and symptoms of asthma are wheezing, dyspnea, coughing, and chest tightness. Patients usually experience one or more types of symptoms with asthma, and these symptoms vary over time and in intensity. They can be worse at night or when waking, and some common symptom triggers are exercise, laughter, allergens and irritants, and changes in weather as well. Symptoms may worsen with viral respiratory infections as well. When a patient is diagnosed with asthma, a physician will consider three separate categories. First is the patient's past medical history for childhood respiratory symptoms, eczema, allergic rhinitis, atopic dermatitis, and food allergies, as well as a patient's family history for asthma and allergies. Next, there will be a physical exam performed looking at the expiratory wheeze on auscultation, and most importantly, the lung function tests. So if there's a expiratory airflow limitation that's indicative of asthma, such as a reduced FEV1, which is forced expiratory volume in 1 second, over FVC, which is forced vital capacity. Next is variability in lung function tests. First, we have the bronchodilator reversibility, which is based on the relative change in FEV1 from the baseline value. So if there's an increase in FEV1 in patients 12 years or older with a greater than 12% change in FEV1, or an increase in FEV1 greater than 15% in patients younger than 12 years of age, Another is a PEF variability, which is peak expiratory flow greater than 13%, as well as an exercise test with an FEV decreased by greater than 12% of predicted or PEF greater than 15%, as well as variability between clinic visits with an FEV variation greater than 12% or a PEF greater than 15%. I would like to mention that not all of the lung function test findings need to be present to diagnose someone with asthma, as well as spirometry cannot be reliably used until a patient is greater than 5 years of age. A patient's diagnosis of asthma is based on both their symptoms that we talked about with wheezing, dyspnea, coughing, as well as confirmed airflow limitation. This will lead to an asthma clinical diagnosis. Next, we will be discussing pediatric asthma severity classification. Asthma severity classification has 3 major categories. We have mild asthma, which is well controlled in treatment in step 1 or 2, moderate asthma, which is well controlled with treatment in step 3 or 4, and severe asthma, which are uncontrolled symptoms despite optimized treatment. I would like to note that it is appropriate to assess severity looking back retrospectively after 2 to 3 months of treatment, from the level of treatment required to control symptoms and exacerbations. The step classification for patients with asthma are for ages 6 to 11 years old based on the GINA guideline updates. Those in step 1 have symptoms less than 2 times a month. Those in step 2 have symptoms 2 or more times a month, or symptoms are not daily. Step 3, symptoms are most days and waking at night 1 or more times a week. And those in step 4 have symptoms most days, waking at night 1 or more times a week, and have low lung function.
Thank you, Abigail, for the review of the pathophysiology and clinical presentation of pediatric asthma. We will now move into the treatment options for the management of pediatric asthma. As Abigail mentioned, my name is Megan, and I'm currently a clinical specialist at Cincinnati Children's covering acute care services. In the management of pediatric asthma, there are different classes of pharmacologic agents that can be utilized. The combination of these agents from different classes will be tailored to the individual patient depending on that patient's severity as well as comorbidities. These classes include the beta-2 agonists, both short-acting and long-acting, anticholinergic agents, again both short-acting and long-acting, corticosteroids. Patients may use inhaled corticosteroids as well as systemic corticosteroids, leukotriene receptor antagonists, and biologic agents. Additionally, patients may require adjunct agents during acute exacerbations. This includes potentially magnesium sulfate as well as others. We will discuss these agents in more detail on the following slide. First class we will discuss is the beta-2 agonists. These agents work by activating the beta-2 adrenergic receptor, which leads to adenylyl cyclase activation, resulting in an increase in cyclic AMP. This causes smooth muscle relaxation and ultimately bronchodilation. Adverse effects to be aware of include central nervous system stimulation, which may appear as nervousness, tremor, and irritability, as well as hypokalemia, and finally cardiovascular effects, including tachycardia and hypertension. Short-acting beta-2 agonists include albuterol and levalbuterol. Long-acting beta-2 agonists include formoterol and salmeterol. When comparing the short-acting and long-acting beta-2 agonists, you will see that the pharmacokinetic differences impact their indication and treatment considerations. Short-acting beta agonists have a rapid onset of action and a short duration of action. These agents, such as albuterol or levalbuterol, are used for acute symptom relief and are not intended to be used as a scheduled maintenance agent or as a single agent treatment option for the management of asthma. Long-acting beta-2 agonists also have a quick onset of action, however, they have a longer duration of action, around 12 hours. These agents, formoterol and salmeterol, can aid in preventing symptoms and are used for chronic management. It's important to note that long-acting beta agonists are not used as monotherapy in the management of pediatric asthma. There is a black box warning for increased risk of asthma-related deaths with long-acting beta-2 agonists. This associated risk is not observed in patients who are also taking an inhaled corticosteroid in combination with a long-acting beta-2 agonist. Additionally, these agents are not intended for use in acute asthma exacerbations. However, when using single maintenance and reliever therapy, which will be discussed in more detail later in the presentation, the combination of inhaled corticosteroids as well as formoterol will be used and recommended as a reliever option. Finally, when comparing the two different agents, so formoterol and salmeterol, we can see that formoterol has a quicker onset of action, a peak effect that is faster, while having a similar duration of action when compared to salmeterol. This is one reason why inhaled corticosteroid in combination with formoterol is recommended in the single maintenance and reliever therapy I previously mentioned. Additionally, the maximum total daily dose allowed of formoterol makes it an ideal candidate over salmeterol for this single maintenance and reliever therapy. Next, we have anticholinergics. These agents work by preventing an increase in cyclic GMP. Adverse effects are typical for anticholinergic agents and include dry mouth, blurred vision, as well as headaches. The short-acting anticholinergics include ipratropium, and the long-acting anticholinergic is tiotropium. I've included this table for your reference. Similar to the beta agonists, short-acting anticholinergics are used for acute asthma exacerbation management, while the long-acting agent of tiotropium is used in maintenance therapy. It is important to note that there are warnings for these agents for caution in use with patients with narrow-angle glaucoma as well as urinary retention, which we can monitor for in patients who are receiving this in maintenance therapy. The inhaled corticosteroids provide anti-inflammatory effects through inhibition of mast cells, eosinophils, neutrophils, macrophages, and lymphocytes. Adverse effects include oral candidiasis, for which patients can be counseled to rinse their mouth after taking their doses, as well as a decrease in bone mineral density and glaucoma. I've included a list of commonly used inhaled corticosteroids for pediatric asthma. The following slides consist of dosing tables from the GINA guidelines, which allow for classification of low, medium, and high doses of inhaled corticosteroids. This information can be used to adjust therapy in a stepwise approach. Inhaled corticosteroids are typically a part of maintenance therapy regimens. First, we have the total daily dosing for patients that are 5 years and younger. We can see we have the inhaled corticosteroid specific agent as well as the dosing for that specific agent. I do want to note that there is a slight difference from the Global Initiative for Asthma or GINA guidelines tables. In the United States, the only currently available formulation of beclomethasone is a breath-activated inhaler, and dosing is device specific, so you may see different ranges reported elsewhere. Moving into the 6 to 11-year-old age group, the doses are now broken up into low total daily dose, medium total daily dose, and finally high daily dose. Again, these doses are agent specific. Finally is the dosing for those over 12 years of age. Again, these tables can be helpful when determining what dose a patient is currently on and how to adjust their current therapy, depending on if they need to step up or if they are doing well and can be stepped down. This will be discussed more when we talk about the management of pediatric asthma. Some patients will require either intravenous or oral corticosteroids depending on the severity of their presentation, and these can be included as part of a patient-specific asthma exacerbation plan. These agents include methylprednisolone, dexamethasone, prednisone, and prednisolone. Adverse effects that can be observed are metabolic effects such as hyperglycemia. You can also see hypertension and mood disturbances with the use of IV or enteral corticosteroids. This table represents commonly used doses of corticosteroids which may be used during an asthma exacerbation. Doses may differ slightly depending upon institution-specific guidelines, and I do want to point out that maxes of up to 80 milligrams per day of methylprednisolone may be used in some institutions. Additionally, for our oral options of dexamethasone, prednisone, and prednisolone, there are liquid formulations available. However, for dexamethasone, due to the high alcohol content of the enteral elixir formulation, some institutions may administer the IV formulation enterally. Prednisone tablets may be split or crushed, and prednisolone is an oral solution formulation. The next class is the leukotriene receptor antagonists, and for this we'll be discussing montelukast. Common adverse effects include rash, headache, and gastrointestinal upset. I do want to point out that there is a black box warning for serious neuropsychiatric events, and this includes agitation, aggression, depression, sleep disturbances, as well as suicidal thoughts and behavior. So when initiating montelukast, we want to monitor our patient for these serious neuropsychiatric events, which may require discontinuation of the agent. I've also included on this slide age-specific dosing recommendations. You can see that it's broken up by 12 months to 5 years, 6 to 14 years, and then those over 15 years. And it's typically dosed once a day in the evening. Next is the biologic therapy. This table represents different agents that are used along with each agent's specific indication. Additionally, I've included dosing references and special considerations. Many of these agents are initiated in the healthcare setting where the patient can be closely monitored, and this is due to the risk of anaphylaxis. So although this slide contains a lot of information, I thought it would be helpful to have as a reference. Finally, we have our adjunct therapy options for acute exacerbations. There are other agents that you may see used, but for the purposes of this presentation, I would like to highlight magnesium sulfate, as this is an agent that may be administered in the acute care setting. Magnesium sulfate relaxes smooth muscle, which can help with bronchodilation. Dosing is variable and ranges from 25 to 75 milligrams per kilogram. Typical doses would be 50 milligrams per kilogram per dose, and the maximum dose would be 2,000 milligrams per dose. This is given intravenously once over 20 minutes. An important adverse effect to monitor for is hypotension, and this may impact where some institutions allow for magnesium to be administered. So it may be allowed to be given on a general floor, or it may be restricted to emergency department or intensive care units only. We will now move into the management of pediatric asthma utilizing guideline-directed therapy. For this presentation, we'll be reviewing the 2021 Global Strategy for Asthma Management, or GINA guidelines, as well as the 2020 updates to asthma management from the National Asthma Education and Prevention Program, or NAEPP. We will first be discussing the 2021 GINA guideline updates. These updates included classification of asthma severity, treatment track and treatment step updates, as well as biologic recommendations. We will begin with the classification of asthma severity. As Abigail mentioned earlier in this presentation, asthma severity is retrospectively assessed and is based on the treatment required to control the patient's symptoms. In order to assess asthma severity, the patient should be on the minimum maintenance regimen required for a few months. Mild asthma is classified as asthma which is well controlled with step 1 or 2 treatment regimens. Moderate asthma is classified as asthma that is well controlled with step 3 or 4 treatment regimens. And finally, severe asthma classification is reserved for those patients who require high-dose inhaled corticosteroid long-acting beta agonist treatment or remain uncontrolled despite high-dose inhaled corticosteroid long-acting beta agonist treatment. I want to take the time to point out that in the 2021 GINA guideline updates, they are no longer differentiating intermittent and mild persistent asthma, and the classification is undergoing ongoing review. Additionally, severe asthma is no longer referred to by step therapy classification. The next update to discuss is the treatment tracks for adolescent patients. This now includes 2 different treatment tracks, the preferred track and the alternative track, and this is based on the reliever that is utilized in the patient's regimen. First is the preferred reliever track, which utilizes low-dose inhaled corticosteroid, or ICS, formoterol as needed for the patient's reliever option. This is based on evidence for reduction of the risk of severe exacerbations when utilizing ICS formoterol as needed in comparison to a short-acting beta-2 agonist as needed. Additionally, this figure shows appropriate management for each step of therapy for adolescents. In steps 1 and 2, the patient will use an as-needed low-dose ICS formoterol. For steps 3 and 4, or moderate asthma, patients will increase the dose of ICS formoterol. And finally, in step 5, there will be an addition of a long-acting muscarinic agent such as tiotropium. The alternative treatment track is recommended if the preferred treatment track is not possible, or if the patient is currently controlled and not experiencing exacerbations on their current regimen. Note, in this approach, a short-acting beta-2 agonist is used as the reliever, and an ICS long-acting beta agonist therapy is not introduced until step 3 or moderate asthma classification. In this track, since the patient is not utilizing single maintenance and reliever therapy, the long-acting beta agonist does not necessarily need to be formoterol, which is why the figure does not specify a specific long-acting beta agonist. Patients may be on an inhaled corticosteroid with salmeterol in this alternative reliever track. Next are the updates for the 6 to 11-year-old treatment steps. GINA has updated these figures similar to the adolescent figures to include single maintenance and reliever therapy for the 6 to 11-year-olds. When looking at this chart, we see the preferred controller treatment steps for 6 to 11-year-olds. The reliever is recommended to be as needed short-acting beta-2 agonist, or there is an option for the low-dose inhaled corticosteroid with formoterol. However, when looking at the maintenance regimen or the controller treatment steps, we see that in step 1, there's a recommendation to utilize a low-dose inhaled corticosteroid when the patient is using their short-acting beta agonist. In step 2, a daily low-dose inhaled corticosteroid is introduced. As patients reach step 3 and 4, the doses of inhaled corticosteroids will be increased, and there's an option for introducing inhaled corticosteroids and long-acting beta agonists. Similar to the adolescents, at step 5, there is consideration for additional therapies to be added on. Other controller options for the 6 to 11-year-olds include considering a daily low-dose ICS earlier than step 2, so initiating this in step 1, and giving the opportunity for an additional agent with a leukotriene receptor antagonist in step 2. For step 3, we can see that there are additional agents recommended in this controller treatment option with the leukotriene receptor antagonist as well, and the inhaled corticosteroid long-acting beta agonist being recommended in step 4. Step 5 introduces the use of a low-dose oral corticosteroid in this treatment step plan. Finally, we will go over the updates to the biologic therapy. And for this, guidelines targeted the biologic therapy, so we have 3 different classes. First, the anti-IgE or omalizumab. This is utilized in patients with blood eosinophils greater than 260, a fractional exhaled nitric oxide greater than 20, allergen-driven symptoms, and childhood onset asthma. The anti-IL-5s are mepolizumab, reslizumab, and benralizumab. These are also recommended for patients who have higher blood eosinophils, more exacerbations in the previous year, as well as nasal polyposis. And finally, anti-IL-4, which is dupilumab. This is recommended for patients with higher blood eosinophils, as well as a higher fractional exhaled nitric oxide. Moving into the National Asthma Education and Prevention Program Guideline 2020 updates, the focus of these updates includes recommendations for inhaled corticosteroids, long-acting muscarinic antagonists, as well as immunotherapy. Similar to the GINA guidelines, NAEPP has both preferred and alternative treatment approaches, which they placed on the same figure. For children who are less than 4 years old, NAEPP recommends initiating a short course of inhaled corticosteroids at the onset of respiratory tract infection, in addition to as-needed short-acting beta agonists. And this recommendation is specific for those who have intermittent asthma. Additional stepwise approach to the management of asthma is depicted in this figure, including escalating inhaled corticosteroid dose prior to the addition of a long-acting beta-2 agonist in step 4, similar to what we saw in the GINA guidelines. Moving to the 5 to 11-year-old age group, the updates to the 2007 NAEPP guidelines included recommendations to initiate single maintenance and reliever therapy with daily as-needed low-dose inhaled corticosteroid at step 3, which is moderate to severe asthma. And additionally, the panel recommends to use subcutaneous immunotherapy as adjunct treatment for those older than 5 years of age. Finally, for those older than 12 years of age, the panel made the same recommendations for the use of inhaled corticosteroid formoterol and immunotherapy as we saw in the previous age group. Additionally, the panel recommended to add a long-acting muscarinic agent to the inhaled corticosteroid formoterol therapy in patients with uncontrolled asthma in step 5.
Now we will be discussing the acute asthma exacerbations in the pediatric population. Acute asthma exacerbations are episodes characterized by a progressive increase in symptoms and progressive decrease in lung function. They represent a change from the patient's usual status that is sufficient to require a change in treatment. 53% of children diagnosed with asthma experienced an exacerbation between 2006 and 2018. It's found that females were more likely to have an acute asthma exacerbation. Children ages 0 to 4 years of age had the highest prevalence of exacerbations. The highest prevalence of those with acute asthma exacerbations are those living under 100% of the federal poverty limit, and 14.7 million outpatient visits, 1.8 million ER visits, and 497,000 hospitalizations are due to acute asthma exacerbations in 2004. This diagram explains the pathophysiology of an acute asthma exacerbation. As you can see, there's an asthmatic airway compared to the asthmatic airway during an acute exacerbation. The difference is that the asthmatic airway has relaxed smooth muscle, but the wall is still inflamed and thickened. During the acute exacerbation, there's bronchospasm and mucus production that causes the classic symptoms of wheezing, coughing, as well as trouble breathing of patients with an acute exacerbation. Some inciting factors or triggers for an acute asthma exacerbation are respiratory infections, environmental allergens such as pollen, dust, and mold spores, mold sensitization, pollutants, poor adherence with their controller, inhaled corticosteroid, and the disease impact of an acute asthma exacerbation. It increases the disease morbidity, increases healthcare costs for the patient, greater progression of lung function loss as well. To diagnose a patient with an acute asthma exacerbation, we're going to look at the patient's history of increased symptoms, frequency, or triggers such as a viral respiratory infection, environmental allergens, and pollutants, as well as looking at the patient for wheezing on auscultation, as well as a progressive increase in coughing, shortness of breath, wheezing, and chest tightness, as well as looking at the pulmonary function tests. A progressive decrease in lung function test is indicative of an acute asthma exacerbation, but it's not typically used clinically for a diagnosis.
Finally, we will briefly discuss the treatment of acute asthma exacerbations in pediatric patients. Each pediatric patient with a diagnosis of asthma should have an asthma action plan. I've included an example of an asthma action plan on this slide. However, your institution may have specific asthma action plans to utilize. This allows patients to have a pathway to help manage their asthma at home. This is typically divided into different sections such as well-controlled symptoms, worsening symptoms, and severe symptoms, as well as how to manage the different situations. For example, when a patient's asthma is well controlled, they will take their maintenance or controller medication as prescribed. When their symptoms worsen, they will be instructed to take their reliever medication such as albuterol or inhaled corticosteroid formoterol. On the plan, the specific dose and frequency will be indicated for each agent that they should be utilizing. Finally, for severe symptoms, the patient may be instructed to initiate an enteral corticosteroid burst and contact their doctor. These plans should also include instructions on when the patient should go to the emergency department for further care. A broad overview of different strategies utilized in the management of an acute asthma exacerbation include the use of short-acting beta-2 agonists, or SABAs, increase the use of inhaled corticosteroid long-acting beta agonist if the patient is utilizing maintenance and reliever therapy regimens, the initiation of systemic steroids, and finally the use of adjunct therapy, which will occur in the healthcare setting. Key concepts for pediatric asthma management include that childhood asthma is a chronic inflammatory condition which is more prevalent in boys. Both the 2021 GINA guidelines and the NAEPP 2020 focused updates for asthma management have recommended the use of inhaled corticosteroid formoterol for both maintenance and reliever therapy in the management of pediatric asthma. And finally, creation of asthma action plans are crucial in aiding the management of acute exacerbations. Finally, we have a few review questions to discuss to end this presentation. Our first question is, JB is an 8-year-old female who experiences coughing and shortness of breath at least 3 days a week. She currently wakes up at night 4 times a week. She has been controlled on her maintenance therapy for the past 6 months. According to 2021 GINA guidelines, which of the following is an appropriate classification of the severity of JB's asthma? A, intermittent asthma, B, mild asthma, C, moderate asthma, or D, severe asthma? The correct answer is C, moderate asthma, and this is due to the frequency of JB's symptoms. She has shortness of breath at least 3 days a week and wakes up at least at night 4 times a week, placing her into the moderate asthma classification. So JB, again, is our 8-year-old female who we have now determined has moderate asthma. According to the 2021 GINA guidelines, which of the following is a preferred controller treatment option for JB's asthma? Is it A, as-needed inhaled corticosteroid and formoterol, B, low-dose inhaled corticosteroid, C, medium-dose inhaled corticosteroid, or D, high-dose inhaled corticosteroid? The correct answer choice is medium-dose inhaled corticosteroid. So for moderate asthma, patients will be treated in step 3 or 4, and for the preferred controller treatment option, a medium-dose inhaled corticosteroid is recommended by the 2021 GINA guidelines. GM is a 16-year-old male who experiences shortness of breath and chest tightness at least 3 days a month. Using the preferred reliever track from the 2021 GINA guidelines, what would you recommend for GM? A, as-needed low-dose inhaled corticosteroid formoterol, B, maintenance and as-needed low-dose inhaled corticosteroid formoterol, C, maintenance and as-needed medium-dose inhaled corticosteroid formoterol, or D, maintenance low-dose ICS LABA and as-needed short-acting beta agonist? The correct answer is A, as-needed low-dose inhaled corticosteroid formoterol, and this is due to the frequency of his symptoms. He has symptoms at least 3 days a month, which would be in step 1. Since this is the preferred reliever track, we will be using the low-dose ICS formoterol. Utilizing the NAEPP guidelines, at which step in therapy may as-needed ICS formoterol be considered for patients 5 years and older? A, step 1, B, step 2, C, step 3, or D, step 4? The correct answer is step 3. Recommend initiating single maintenance and reliever therapy at step 3 with inhaled corticosteroid formoterol. Finally, at which steps does the NAEPP 2020 focused updates recommend the use of immunotherapy for children 5 years and older with asthma? Is it step 1, B, step 3, C, step 4, or D, all of the above? The correct answer is D, all of the above. We have included the references on these slides for you to have and look at if you have any questions. And that concludes our presentation on pediatric asthma management. We'd like to thank you for your time.